right, so this is our drip class. Here are our listed objectives. First thing we're going to talk about is drip hygiene. So iTrace is very important with drip hygiene, so you always do iTrace anytime you're hanging or handing off a medication. Titratable medications must be hung as a primary infusion on its own pump. You don't put Levophed on Propofol, Precedex on Propofol. You don't do any of that stuff, okay? You have to have them separate. So you can Y-site, but you should never piggyback titratable drips, okay? Even if it's on a primary fluid. So even if you have NS and then you can't put Precedex on the NS, you have to have Precedex on its own pump, all that stuff, okay? Make sure medication is going through proper vascular access. So you have peripherals, you have midlines, and you have central lines and PICs. Midlines are not central lines, so you cannot be putting certain, like pressors, you can't put them through a midline. We have to order new bags from pharmacy 2 hours in advance. If not, you could risk it's not going to show up, okay? And you would have to mix it yourself. You should document the start, titration, stop, and restart of medications in Meditech. Currently, this is only in PCU, but we will be switching over to this probably sometime this month. It's called Iatrix, but you'll have to document any titration that you do in Meditech. So, moving on, let's dive more into iTrace. So with iTrace, we want to illuminate the area, turn on the light, make sure you can see the medication that the pump that it's on and the site it's infusing to. We want to review. So the T is the track. It's not on the slide, but I'll add it in. T is tracking it. So you're going from the bag to the pump to the point of insertion. You need to then review the orders. So review the orders to assure that this is the right patient, right solution, right route, right drug, right rate. Also assure that this is the right tube and the right connection. Act immediately if anything is wrong. So if it's the wrong patient, solution, route, rate, tube, or connection, correct the process, recheck, and continue. If this is the wrong patient, drug, dose, route, or rate, you must do an occurrence report. Expectation is that you do iTrace with transfer of care during shift or during formal report. Moving on, compatibility. If you're going to infuse multiple medications at the same time, you have limited access, you can run a compatibility report to determine if medications are Y-site compatible. The way you would do this is by going through Meditech. On the right-hand side, you can then click references, and clinical pharmacology will be one of those references. Clinical pharmacology will launch via the internet, and then you can go to reports and run an IV compatibility report. You would then put all your medications that you would be infusing, and the report will show which medications are Y-site compatible. This report then can be printed if needed and put up in the room. Okay, so you always know. So you can put on there Levo, Vaso, Propofol, Precedex, Vanc, Zosyn, all that stuff. Now, just know in general that a majority of your sedatives are all compatible with one another, and a majority of all your cardiac drips are compatible with one another. So if you have a triple lumen, the general thing that people will say is put your sedatives on one, your drips on the other, and then you have a third port for IV pushes and antibiotics, okay? As far as running your sedatives with your pressors, it's typically frowned upon unless you have multiple IV access. If you have very, very limited IV access points, the problem is that we do sedation vacation. So you will need to pause your sedation. Also, Propofol will require you to do a tubing change. So if you do a tubing change, some of that levo is then not going to be going into the patient. As far as what goes closest to the patient, you want the fastest thing going first and then the slowest thing going behind it at all times. You don't want to put something that's supposed to be going slow and then something fast on top of it, okay? So that's as far as Y-site. You want the fastest thing going first to the patient. Now, as far as ordering drips from pharmacy when you're running out, you can do this of two ways. Missing medication request if out of a drip that's stored in the Pyxis. So Propofol, say we're running out of Propofol, there's no more Propofol in the Pyxis, you can do a missing medication request. You would go to the medications, the Meditech status board, variants, missing medication request, the first three of the last name of the patient followed by the first three of the first name of the patient. You would F9 and look up the patient's name, look up the medication, put in the time that you need it and the reason you need it. That is going to be for medications of drips that are in the Pyxis. Now, other drips are made by pharmacy, such as Levophed, Vasopressin, Ketamine. These medications must be ordered 2 hours before you need it. These are drips that you need follow-up for. These need to be ordered 2 hours before. How you do that, whether you calculate it, you put on a shorter amount of volume on the pump, etc. Like me, anytime I hang a drip, I always order the next one so it's ready. Okay, if I predict it'll be needed in 5 hours, I'll put it on there. 5 hours, I'll need it, but I always order it after I hang it. As far as putting in these orders, this is like an order from a physician. So you'll go to Meditech status board, go to orders, and put a new order under the physician who ordered the drip. The order source is Z for Z processes. You would then type in MMM. This stands for Medication Management Message. Input the info for when you need it, the current rate, and when the last one was scanned, and pharmacy will deliver it. Documenting. Always scan the medication first before actually starting the medication. Meditech will prompt a second verifier if necessary. The second verifier must I-trace at bedside with the primary RN. If you put your 3-4 in there, what you're saying is you did all that. So if something was messed up and you trusted somebody and it was wrong, you said you verified it. So not only they are accountable, but you are also accountable. So make your wise decisions whenever you're giving people out your 3-4 ID. If the patient is in PCU, which now it'll be in ICU as well, we would document the initial rate and titration of the medication intervention under IV drip titration. This information includes the medication, whether we're starting, titrating, discontinuing, or restarting, the dose, the rate, and the parameter at which we're titrating. So if we titrated it because of blood pressure, we would put on there because of blood pressure. Then we document under IV drip titration anytime we titrate the medication, but that's at a minimum of 15 minutes, right? So say we titrated 5 times in a 15-minute time span. I just needed to titrate it, say like it's 12 o'clock. And then from 12 o'clock to 12:15, I titrated it like 4 different times. I don't need to do it 4 different times. I just need to do it at 12 o'clock and 12:15. Okay, so every 15 minutes, just like how you would on your flow sheet. Okay, you don't document every single one every 5 minutes or whatever. Make all those little mini X's. If the patient's in ICU as of now, we're documenting it on the flow sheet. Just make sure that you remember anytime you're titrating, there needs to be proper documentation of what you're titrating to. So if you're titrating up your pressors, I better see a blood pressure that says something low, that says like a map of less than 65 or whatever we're titrating it to. Same thing for sedation. That's why if you have a sedative, you need to document in Meditech at least every 4 hours what their RAS is. But if you're going up on their Propofol, I better see on the flow sheet that the RAS is +2 or something like that, okay? Now, the following drips are able to be done in PCU and ICU. The first one is going to be dopamine. Dopamine is a variety of things. It's an inotrope, it's a chronotrope, it's a vasodilator at some doses, and it's a vasopressor at other doses. It just depends on the dose that it's going at. It's a positive inotrope, thereby meaning it increases contractility. It's a chronotropic agent, so it means it can increase heart rate. Vasodilator decreases systemic vascular resistance. Vasopressors increase systemic vascular resistance. So, mechanism of action changes at different doses. At low doses, this is just a vasodilator. So you'll often find that this can then, you'll see increased urine output at this dose. So people with CHF, they can be on a little bit of dopa, and then they'll pee, and they're not going to be as overloaded. Moderate doses, this is going to be a positive inotrope and a chronotropic agent. So this will not only increase their heart rate, but it'll also increase their cardiac output. They will still have some vasodilatory effects. At high doses, this is not allowed in PCU because this is a potent vasopressor at this point. All this is doing is clamping down on their vessels. There are listed side effects. Dopamine must be infused via central line. There is our titration protocol. The max in PCU is 10 because that's when it becomes a pressor. The max in ICU is 50. Dopamine, this is another positive inotrope. So it increases your contractility and it also can increase your heart rate. Side effects are listed there. This is also must go through a central line. There's your titration. Your max of dopamine is 40 mics per kg per minute. Remember, eye trace is important. Dopamine looks close like to dopamine, but they're different. Primacore, this is another positive inotrope. Primacore is also known as milrinone. Side effects listed below right there. We infuse via central line. There's your titration. By no means do you have to remember your titration. That's why you have your EMAR. Okay. I'm just showing you. Max is 0.7 mics per kg per minute. Bicarb. This can technically be a titratable drip. We usually don't titrate it though. It's usually a set rate, but it's in here listed because my boss said she wanted me to put it in here. So bicarb is given for acidosis. Pharmacy has to check actually for the necessity of the bicarb drip because we were in a massive bicarb shortage and we use bicarb like it's candy here. And a code blue at this hospital, we'll give the patient bicarb before we even give him epi. This is an alkalizing agent. Side effects of bicarb are hypernatremia because it's sodium bicarb. And they can develop alkalosis. We infuse per physician order, either through a peripheral or through a central line. Usually, they'll come in liter bags with usually 2 to 3 amps of sodium bicarb in them. Bumix is your next drip. This is given for fluid overload. Bumix is a loop diuretic, acting to prevent sodium and water retention. Side effects are listed there. Titration. This can be prescribed at a set rate, but it can also be titratable to urine output. Now, the standard protocol is for urine output greater than 30 mLs per hour. It does not state what the max urine output is, so this you need to notify your physician with. So if I'm giving them Bumix and they're peeing like 400 an hour, is that okay with them? Maybe, is this patient super overloaded? Do you want them peeing 400 or do you want me to come down on the dose? That's going to be determined by your physician, okay? Monitor urine output every hour via Foley catheter if able. Antihypertensives, Cardizem. Cardizem is given as an antihypertensive medication during hypertensive crisis or emergency. The problem with hypertensive crisis or emergency is that this is uncontrolled hypertension. This puts the patient at a massive risk for stroke. We don't want their blood pressure 250 systolically, 150 diastolically, okay? If they're on a Cardizem drip, there will be strict SBP goals. If their SBP drops below 160, we stop the Cardizem. Because if you put the Cardizem on and their blood pressure's in the 100s, they can also stroke because their body's not used to a blood pressure that low. They want a higher than normal blood pressure, similar to your kidneys. Okay. Cardizem is a calcium channel blocker and vasodilator. Side effects are listed there. There's your titration. It's a pretty easy drug to titrate. It's 2.5. We titrate by 2.5 every 15 minutes. The max is 15. We can infuse Cardizem via peripheral, but we have to change sites every 12 hours, or it can go continuously through a central line. So if we have 2 peripherals, it's going to go through my peripheral on my left for 12 hours. The next shift is going to switch it to the right, and then we could switch it back to the left the shift after that. But it cannot go continuously through a peripheral. That's including a midline. So if you have a double lumen midline, you can't just change ports. It's going through the same vessel. Amiodarone is an antiarrhythmic for tachycardias. There is your listed side effects. Must go through a central line. Bolus is typically given whenever you're starting the drip. The bolus is 150 milligrams to go over 10 minutes. And then we would start the drip at 1 milligram per minute for 6 hours and then decrease it to 0.5 milligram per minute for 18 hours or continuously. This is overall better for patients who are hemodynamically unstable compared to Cardizem. Cardizem is another antiarrhythmic given for tachycardias. This is a calcium channel blocker. Thereby it inhibits the contractile process of the heart muscle, but it also has some vasodilatory effects. Thereby, this Cardizem causes a lot more severe hypotension compared to Amiodarone. It can be infused via a peripheral or a central line, and we infuse it by the titration criteria listed. Other thing we learned about Cardizem is that it increases your Prograf levels. We don't like increased Prograf levels because it's toxic to the kidneys, okay? Insulin is your next drip. This is given for hyperglycemia, DKA-HSS. It facilitates the uptake of glucose into the muscle and fat, inhibiting the glucose production by the liver. Side effects, obviously hypoglycemia, but also hypokalemia. We infuse per physician order or endotool. We can infuse via peripheral or a central line. When starting insulin drips, if we're starting with new tubing, we must prime the tubing with 30 mLs of insulin. This is going to coat the inside of the tubing because insulin's pretty sticky, and that way we're not having any occlusion issues. We will replace the potassium as needed. Every insulin drip comes with the hypoglycemia protocol, so if you need it, you can use it. Next drip is heparin. Heparin is our anticoagulant used for DVT, PE, or MI. We have different protocols, one for DVT and PE and one for an MI. They are different in their titration. You can give a heparin through a peripheral or a central line. With heparin titration, we currently have a paper that we have to fill out. Anytime you titrate on a heparin drip, you have to notify the charge before you do it. To clarify, that's your second person, and you would document on the sheet. There have been unnecessary amounts of heparin medication errors. Thereby, that is why we have the sheet, to double check every time. You don't just have to change the heparin drip off of what you think. Argatroban is the anticoagulant of choice for patients who have HIT, which is heparin-induced thrombocytopenia. So if you need anticoagulation but you can't get heparin, you get Argatroban. Side effects of this is it is a anticoagulant, so bleeding is also an issue, just like with heparin. And we titrate off of hepatic function. So if they have normal hepatic function, they're going to get a lot more Argatroban than if they have hepatic impairment. And we titrate according to PTTs as well as with the heparin drips. The difference is with heparin drips, we do PTTs every 6 hours. With Argatroban, we do PTTs every 2 hours after starting and 2 hours after every dose change. Now we will continue with the ICU drips. So all the drips that I've listed so far are drips that they could do in PCU. These drips that I'm now going to talk about can only be in ICU. First one's Propofol, favorite one. Magic drug. This is given for sedation for intubated patients or those receiving conscious sedation. If you're doing conscious sedation, that means that you don't have an airway. You're pushing sedatives. Thereby, a physician needs to be at the bedside. You don't give pushes of Propofol if there's nobody there and you don't have an airway. Propofol is a GABA agonist. Side effects are listed there. One of which I'd like to point out is hypertriglyceridemia. Thereby, we do check triglyceride levels typically on these patients after 3 days to determine if it's high. Because if it's high, they're at risk for fat embolism stroke. Propofol max is 50. We titrate according to their RAS. Infusion considerations. This is stored in the Pyxis and does not need an order via MMM. Patient either must be intubated or have a physician present during administration. We have to change tubing and blue caps every 12 hours and flush the line. Okay. Put in a clear controlled substance box if available. That's preferable. Hand off your controlled substance at change of shift. Zero your pumps at 2, 10, and 6. Those of you who work night shifts, you know the importance of zeroing the pumps. Day shift, y'all messed up. Zero your pumps. Be nice to your night shift, because then they have to calculate what you should have already done. Okay. If you come in and the pumps aren't zeroed at shift change, zero the pumps. It's less hours that you have to calculate. Sedation holiday, also known as awakening trial, is recommended every 12 hours at the beginning of shift. Precedex is your next sedative. Precedex does not have to be given on patients who are intubated. It can be given on patients who aren't intubated. Precedex will cause bradycardia. Okay, so if your patient becomes bradycardic, pause your Precedex. The titration is there as follows. The max rate is 0.7, but it can go up to a max of 1.4. Considerations. This is mixed in the ICU in a 100 ml NS bag, so make sure you place a label on it. You don't need to place order via MMM because we mix it ourselves. Avoid abrupt discontinuation. Sedation vacation at the beginning of shift is advised. The patient does not have to be intubated. You still zero your pumps. This is not a controlled substance, so it doesn't need to be in the clear box or handed off at shift change. Versed is your next sedative. This is a benzo. There's your titration. It can cause tolerance, just so you know. Considerations. It is stocked in the Pyxis, so it does not need to be reordered via MMM. This needs to go in a clear controlled substance box and handed off at shift change. Make sure to zero your pumps and do your awakening trial at the beginning of your shift. Fentanyl is your next sedative. This is an opioid. You can cause tolerance with the fentanyl drips if you're using it for sedation, because you can't tell if they're in pain or not. They're not showing typical signs of pain. They can't say, I'm in pain, give me more fentanyl. So we can put them maxed on the fentanyl and they're not in any pain and they're getting fentanyl for days. It can take up to 6 days to actively withdraw them from a fentanyl drip. So just because the max is 200 doesn't mean that you just bump it up to 200. That's a lot of fentanyl. Every hour they're getting 200 mics. That's a lot, okay? Considerations. This is stocked in the Pyxis, so it does not need to be ordered via MMM. Make sure to put it in a clear controlled substance box on the IV pull. Make sure to hand off controlled substances at change of shift, zero your pumps, and do your sedation holiday at the beginning of your shift. Ketamine is your last sedative that we use most often here. There's your titration orders. This can cause trance-like hypnotic. This is a trance-like hypnotic agent, so their eyes may remain open, so you can tape their eyes closed if their eyes are not closing. Order via MMM from pharmacy at least 2 hours in advance. That'll then be delivered to the pharmacy, delivered to the Pyxis. Document the stop and waste. This used to be on a yellow controlled substance sheet. They now changed it to Pyxis only, so you don't have to worry about this yellow sheet that the slide's talking about. You're going to put it in a clear controlled substance box and an IV pull. Do your handoff at shift change, zero your pumps, and do your sedation holiday. Now we're going to talk about the 5 pressors. Levo's your first one. Levo is an alpha adrenergic receptor agonist. It can cause necrosis if their extravasation occurs, and it can also cause mottling. Okay, you have different titration orders. You have non-weight based and you have weight based. We have transitioned to weight based pretty much all in all. There are a few physicians who like just non-weight based Levophed, but the problem is that the max rate of 100 mics per minute, that may be a lot for one person or it may not be enough for another. So that's why we do it according to their weight, okay? There is a cardiology Levophed. Don't ever do it. We don't do any of that stuff. They have lower maxes on that. Considerations. Infuse via central line. Monitor blood pressure every 15 minutes. It can be different strengths. Single strength, double strength, or quad strength. Single strength is 4 and 250. Double is 8 and 250. And quad is 16 and 250. This will not change the dose. It just is more highly concentrated. Thereby, if they have a stronger strength, they are taking in less fluid. So make sure this aligns with what's on the pump, especially if you're switching from single strength to quad strength. Make sure the pump is set to what is on the order. aka weight-based or non-weight-based, and if changing strengths, always started on a new pump with new tubing, and titrate off of the old strength to the new strength. So you're starting them both at the same time, and then you titrate off of the old strength. You will have crossover, but if you stop one strength, so if you stop single strength levo and then put on quad strength, remember, all that tubing still needs to be filled with the quad strength, and it's going to be going 4 times as slow. So you need to make sure that you're doing that safely, so that way they don't become hypotensive. Order via from pharmacy via MMM 2 hours in advance. If the patient is on quad strength and infusing less than 2 hours, so say they're on quad strength and you're still running out of fluid, you're running out of that bag in less than 2 hours, then you can get what's a double bag. So this is quad strength levo in 500 mLs. That's a lot of levo. Then you can do that, but you need to talk with pharmacy about it. The other thing we can do is we can mix it in D5 if the patient is hypoglycemic. So if you have these liver failure patients, you're trying to reduce the amount of fluid that's going in them, you can ask to mix your drips in D5 instead of NS. You may save them from getting a D10 infusion. If you run out of your pressors, mix them emergently with another RN. Okay, don't just let them die. Okay, change the pump to prevent this. So here's the problem. Typically, every time we start something on the pumps, when it runs out of fluid, whether or not there's fluid in there or not, when it runs out of fluid, it's gonna run KVO. This is 1 ml an hour, okay, on the pump. So, say I'm over here and I'm hanging my Levophed, and I say, okay, I'm going to order another bag when 150 mLs has infused. And this is a 250 bag, so I know that there's going to be 100 mLs left. But then say I get stuck in my other patient's room, and now the 150 mLs is up. So the pump thinks I'm out of fluid, but I'm not out of fluid. It doesn't matter. If the pump is set to run a post-infusion rate of KVO, it's then going to go from running whatever it was, 75 mLs, 50 mLs, blah, 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 and it's going to now stop and it's going to run 1 ml an hour. So say I'm in my other patient's room. I can't hear the pump. Say everybody else is in their patient's room. They can't hear the pump. How many times is the pump beeping and you just walk by, even though you shouldn't? Or you're sitting at the nurse's station and you're like, they'll figure it out eventually. You don't know what's beeping. It could be a pressor. And then it goes from running at 75 mLs an hour to 1 ml an hour. And if you have somebody who's super sensitive, guess what? The pressure is going to drop. And even if you have fluid in there, the pump doesn't know that. The thing that you can change the post-infusion rate from KVO to whatever the current programmed rate is. So if the pump is going at 75 and it runs out of volume, as long as there's no air there, it can continue to run at 75. But you must change the post-infusion rate. If you don't know how to do this, talk with your preceptor. If not, there's a video on the YouTube channel on how to do it. Think before getting them up if they're on pressors. Remember, they're going to vasoconstrict off their peripheral extremities, so they're going to have a higher risk for orthostatic hypotension. They may be very sensitive or labile with dose changes or positioning changes. So if they're on a bunch of levo and you turn them and they get hypotensive, you turn them back, okay? Don't just leave them turn. Phentolamine is the drug that's given for extravasation. So if it infiltrates and it's sitting there, guess what? You're going to draw up your phentolamine, and you're going to have to inject phentolamine into all the tissue. And you're going to do it because you're the one who infiltrated, who put your pressors on an infiltrated line. Because if you don't give them phentolamine, then it's going to become necrotic tissue, and you're going to have another issue. So don't put pressors through peripherals unless you absolutely have to and you're already going to be getting a central line. Okay, vasopressin is your next pressor. Vasopressor is a hormone-based vasopressor. It acts differently than your alpha agonists. Okay, this is going to vasoconstrict your coronary, splenic, GI, pancreatic, skin, and muscular vascular beds. It also has an antidiuretic effect. Titrations listed there. You have your max of 0.04 units per minute. Considerations: goes through a central line. Monitor your BP every 5 minutes. It's ordered via MMM at least 2 hours in advance. Change your post-infusion rate from KVO to rate. Start for GI bleeds because it's super helpful, but otherwise it's typically your next pressor after Levophed because it acts in a different mechanism. If so, max them on Vaso. If you're starting Vaso, then basically you should max them out on Vaso and then decrease your Levophed to prevent complications of high-dose Levo, such as tachycardia. Mix in D5W if the patient's hypoglycemic. Neosynephrine is your next vasopressor. This is an alpha agonist. There's your titration sequence, and you have the same sequence of considerations as your Levophed. Okay. Epinephrine is your next one. Epinephrine is not only a pressor, it's also an inotrope and a chronotropic agent, so it's going to increase heart rate, contractility, and it's going to cause vasoconstriction. You have your non-weight-based and your weight-based. Now for epi, we typically do non-weight-based instead of weight-based. Same considerations as your other pressors. Now, we've talked about all of your pressors. The thing about all of your pressors are alpha agonists except for Vaso. So here's the problem. You have a set number of alpha receptors in your body. Once you put something on them, then that's it, right? Once they're all saturated, then that's it. That's why at some point you can go up and up on your pressors and they're not going to do anything. So that's what the advantages are of using Vaso, is because Vaso uses a completely different mechanism of vasoconstriction than the rest of them. The rest of them are all alpha agonists. Vec is your next one that we will talk about. Vec is a paralytic. Side effects, obviously, it's going to cause apnea. So don't give paralytics to people who don't have an airway unless you're intubating. There's your initial rate. We titrate paralytics with train of 4, which basically we're checking for, we're stimulating their nerves to cause a twitch. If they're paralyzed, then they're not going to have any twitches. And we titrate according. We don't want to completely paralyze them, but we want to make sure that they basically, like, they're paralyzed but not completely paralyzed. It's just like light paralytic. Every person who's paralyzed always has to be sedated. We typically give paralytics for ARDS or patients receiving therapeutic hypothermia. The reason why is because with therapeutic hypothermia, you shiver. When you shiver, you produce a lot of CO2. So we paralyze them so they don't shiver. Produce CO2, because if you produce CO2 when you're trying to have therapeutic hypothermia, then you can cause brain injury. Octreotide. Octreotide, we've talked about, inhibits the secretion of hormones involved in vasodilation for variceal bleeding. This is infused either peripheral or a central line at a set rate of 50 mics an hour. This helps stop the bleed, so you should actually start it. There have been many times where the octreotide is ordered, but it's never hung, and they keep going up on pressors and all this stuff, when octreotide is actually going to help stop the bleed. The pressors aren't. Other drips I'm not going to talk about, but you could see. Morphine, given for comfort care. Phenobarbital is given for seizures or alcohol withdrawal. Nitro is given for STEMIs or hypertension. Lasix is another drip that we can give for diuresis. Esmolol and labetalol are given for hypertension, also for antiarrhythmics. Ativan can be given for seizures or alcohol withdrawal, and Vecuronium is another paralytic drip that we could use. It's over. It's finally over. Congratulations.